Hey guys, my name is Matt McCoyd. If we haven't met in person, if you're taking the API course, you'll probably hear me give some of the lectures. I'm always really interested in your guys' feedback on those lectures in terms of if you think they're helpful, where I can improve them, etc. If you're a current fourth year resident, this is a great time to kind of start. If you're someone who's maybe already completed your residency training, you've been delaying, or just haven't had the opportunity to take the test, this is kind of a kickoff session. Right? My experience, I've been the residency director at Loyola for about 12 years. So I've been going through this process as a residency director, as someone who took the exam and the recert when we had to do that, and I've been working with API for over a decade. I always found like right now is typically when a lot of my senior residents start really kind of taking a look at the board exam. We certainly talk about it, throughout the 4 years, and realistically, you've been preparing for this exam for the last 3+ years or longer. Now's the time when I think a lot of people, they're hitting the second half of the academic year. They're getting within a couple months of the examination, maybe if you're not even in an academic year. And you're really starting to look down the barrel thinking, that examination is starting to come. And I even though I'm always kind of constantly learning and preparing in neurology, I really kind of want to get started specifically with board preparation. So I do think now's a great time to get started. There is a pretty high volume of content, but it's very manageable if you're starting now, which is what you guys are doing. And again, I would stress the majority of the information on the board exam is stuff that you guys have been living and practicing for the last several years. The examination is just trying to confirm the competency and basic knowledge around these topics. So when I talk to my residents, this is a point that I really emphasize. Now, if you're a current trainee, if you're a recent trainee, you have probably taken the American Academy of Neurology's residency and service training examination. The AAN and the American Board of Psychiatry and Neurology and the ACGME, the American College of Graduate Medical Education, are organizations that are oftentimes very similar. They have similar goals in terms of establishing sort of the information that residents and physicians should have, but they are a little bit different. For most of our residents, they just took the right exam. It was just a couple of weeks ago. That can be a daunting exam, to put it mildly. If you think about, if you know what I'm talking about when it comes to the right, and you think about that test, my experience, having been around for a little while, if you score greater than 70% on the right exam, that generally puts you in the 90th percentile for the country, right? I can tell you one of our residents, I believe, got in the 98th percentile in the country one year. Obviously an outstanding score. I think he got a 78% on the test. I think that gives you an idea of the challenge of the right exam. It is designed to be an incredibly difficult test, where it is incredibly uncommon to score 80 or 90%. Its goal is to stratify residents from the 1st to the 99th percentile with an incredibly steep peak right there at that 50th percentile. I've seen residents maybe 1 or 2 percentage points above or below a colleague, and their percentile in the country will dramatically shift. So my experience is the residency in-service training examination tends to skew more towards the esoteric. It tends to include a great deal of pathology, and a great deal of what I feel are at times sort of neurotrivia or obscure radiology. It is a good exam. If you performed well on the right exam, you are statistically going to perform well on the AAN exam or the ABPN exam. Both organizations have published literature, they periodically update it, that try to correlate right scores to board scores. If you do well on the right exam, I believe the number is greater than 65 or 60 to 65%. You statistically have a very high correlation with passing the exam. If you scored under 60%, you still have a high correlation of passing the exam. Right? And I think that speaks to the challenge of the right exam. So just a constant point that I emphasize with our residents, the board exam is not the right exam. The right exam is much more of a neurotrivia. If you do well on the right exam, you're going to love NeuroBowl at the American Academy of Neurology annual meeting. I hope you're going this year in Seattle. It's a little bit more like Jeopardy than what the board examination is trying to emphasize. The board examination is really trying to emphasize common topics and establish a core competency when it comes to your medical knowledge as a neurologist, right? So it sort of changes your thinking a little bit. One thing that I really like to emphasize, just think about that. So great, they're gonna ask me. They're really going to potentially try to emphasize do you have the core medical knowledge around neurology? So what do I need to know? Neurology is a big topic, a big field. If you're talking to different faculty members, everyone's got different areas that they think are important, et cetera. So one of the documents that I have really come to appreciate and really try to emphasize, both in my teachings in the API course as well as with my residency program, is the ABPN's board examination blueprint. So if you go to the ABPN website where you signed up for the exam, they will list under certification, you can find the content outline. They started doing this back around 2017. At that time, there was a big push nationally for board reform, really spearheaded by internal medicine. And one of the things physicians wanted was more transparency in terms of what was on the examination so they could prepare properly. And as a result of that push, a number of the organizations in the ABPN specifically started publishing their content outline. I have found this document to be extremely helpful. I'm willing to accept that it is long. It is about 37 pages long in a bulletproof format like I've got up here, but I think it's extremely high yield. The document, as I look at it, sort of has two parts, dimension 1, dimension 2, which I'll get into here briefly. But to me, this is your board exam. This is the information that you would really need to know. Now, I find that some of the topics, most of these topics are common. If you're someone who enjoys any of the neurology review books, Adams and Victor, Continuum, et cetera, these are your common core topics. And actually largely reflect the ACGME milestones, right? The major topics neurologists need to know. Then I will bullet point them, which I will get into. My feeling is if something isn't in this content outline, though it's possible it can be tested. Every section includes an other, sort of a catch-all. But man, you can do a lot of studying looking for other and spend a lot of time on things that really are esoteric and don't change your score all that much, right? So nailing these questions that will be on there, I think is really, really critical. All you're trying to do is get past a passing threshold. So dimension 1 sort of lists big, broad buckets. That doesn't help you all that much. The percentages kind of give you a rough idea, kind of what's there. But that's sort of your overview, right? That's your ACGME milestones. Those are your continuum topics. Those are your kind of big headliner topics. Dimension 2 is very short. This is all they show you. Dimension 2 really kind of tells you what are the questions going to ask you about, right? So if they're going to ask you about a specific diagnosis, well, what would the question be about? Well, it might be about mechanism of disease, so kind of basic neuropathology or pathogenesis. Really a strong emphasis on clinical aspects. How do patients present? What's the appropriate testing you need to do? How do you manage these conditions where we know that there's management? I'm going to get into that topic as well in a little bit. Those are probably the core of your examination. And if you look at the percentages, that is pretty close to about 80% or so, right? So the fundamentals, can you make a diagnosis? Can you take a history, localize it, make a diagnosis, and how do you manage this? The bottom part is some of the other almost ethics, interpersonal communication, professionalism, practice-based learning systems, et cetera. So dimension 2 kind of gives you an idea, well, how they're going to frame the test question. All right. Where I like the content outline is in this part. That first part says, hey, these are the broad topics. If you go into that outline, and most of our, if not all of our speakers do this, I know I do specifically for my lectures, they bullet point the topics you need to know, right? So it is very specific that you need to know about, for example, migraines, tension type headaches, cluster, and then other primary headache disorders. My feeling has been this is really the kind of meat of the exam. And again, I think some of these are more obscure than others, but if they listed it, I think it's fair game. Generally speaking, they're going to go after the sort of most common and core things the most. But I've always felt like if it's on the outline, we should at least think about it, and I should know something about it, particularly some of the fundamentals. I think this is perfect for creating a study guide, writing note cards, whatever you think you need to do in terms of just sort of organizing your thoughts and information around it. So it is a lot of content. Again, I would emphasize, hey, this is stuff you guys have mostly been doing, right? I mean, if you think about your continuity clinics, if you think about your personal practices, what you do in the hospital, Well, you treat migraine headaches all the time. You deal with cluster headaches. You deal with tension headaches. You've dealt with patients with idiopathic intracranial hypertension. They're not going to ask you, for the most part, they're not going to ask you incredibly obscure things that aren't part of your practice. They're looking to establish competency around the common neurologic topics. And what this content outline does is it gives you a very, very good idea. Man, what's the most high yield stuff I should know? I'll make this point a couple times. Answering a question correctly about carpal tunnel gets you as many points as answering an obscure question about Susak syndrome, right? So take the easy points and kind of move on. So other kind of things, kind of emphasizing that. Really important thing to think about is taking the test. Don't outthink the test. I think that there's a tendency to approach the board exam and go, this is going to be the hardest exam. And it is a challenging exam. This is not an easy exam. It's an exam I think you very much have to prepare for. You have to prepare for it throughout the 4 years of training. You need to prepare for it in the couple months here you got coming up to the test. I think it's a legitimate exam. I think it's a fair exam. I think if you prepare for it, you can very much pass the examination. But I think there can be a tendency. So this is the board exam. This is the kind of big end all be all. And they're going to ask me something really, really challenging. They're not going to ask me a common question. So for example, you'll get a patient. I don't know what's on the exam, but just as an example, they'll give you a patient and they say, listen, the patient's, these 3 fingers are sort of numb. They got to wake up at night and shake their hand out. They're sort of dropping objects. What's your diagnosis? And you're going to think to yourself, man, that sounds like carpal tunnel, but there's no way they're asking me just a simple carpal tunnel question. And for the board exam, they're asking you a simple carpal tunnel question, right? Don't talk yourself into something super obscure and esoteric. Kind of focus on the common stuff, right? Just think, what would I do in clinic? If I saw this patient in the clinic, if I saw this patient in the hospital, what would I diagnose them with? And they're more likely to ask you common questions about common diagnoses than uncommon questions about uncommon diagnoses on this examination. So when I've gone to the meetings at the American Academy of Neurology and listened to these organizations speak, that's a point of emphasis. They have a high bar for certification, but their goal is to confirm that you have achieved competency when it comes to medical knowledge in neurology. The goal is not, for the most part, to confirm esoteric knowledge, right, or extreme kind of neurotrivia. Even though if you know it, that's awesome, and it's going to make the test easier, and it's also just sort of fun. So generally speaking, a question is far more likely to be about common disorders like carpal tunnel than obscure diagnoses. Don't think it can't be a normal. So sometimes normal is normal. A patient with a non-specific examination and a non-specific headache might have a normal head CT, right? Don't try to outthink it and go, well, there's no way they're going to give me a simple normal head CT. You didn't train to be a pathologist. They're not going to overly emphasize obscure pathology pictures. That's not what we do as clinicians, right? It's not the role of the neurologist to look at path slides and make diagnoses. Our goal is to understand who needs a muscle biopsy and what am I kind of big picture diagnostically looking for. There will be some pathology on there. Generally speaking, it has stuck to maybe the most common diagnoses and really common presentations of them. This is not a pathology exam. It's a neurology exam. Another part, and this is another place I see the board exam really diverge from the in-service training exam and from continuum questions, for example. The board tends to avoid areas of controversy, and it will generally go towards things that are widely agreed upon. Well, I've had the opportunity, I've not written questions for the ABPN, but I've written questions for some other board agencies, and they want exam questions that are fair and questions that we agree on. So think about that. You can't write a question, what's the best treatment for multiple sclerosis? You're going to get in a long argument with a lot of really intelligent people as to what the best treatment is in different situations. So you tend to avoid those. What can you ask about? Well, you can ask side effect questions, right? Maybe I don't ask you what the best MS med is because that's a debate. But where they can really try to emphasize things is, well, what are side effects of the common medications? When can't you use a medication? What should you know about a lot of these meds? That'd be more important than knowing, but what's the specific efficacy of a drug? What percentage does it reduce your risk by? How much does that matter? What really matters, well, do you know the side effect profile? Do you know who's contraindicated from using a medication? Is there a specific indication to use a certain medication? I've also found one other thing that can be extremely helpful. Read the question stem first. sometimes the board exam will give you this incredibly long, verbose question stem. At the end of that stem, what's the side effect of natalizumab? Well, maybe I didn't need the question stem to answer that. So I got in the habit, and I have my residents try to get in the habit. Usually the last line is the question that frames what I'm looking for in the content, and then I'll go read the content outline. So focus a lot on what a neurologist does. I think is also critical. For in-service exams, sometimes memorizing genes is a big deal. I think for the most part, memorizing specific genes or the chromosome they involve isn't all that helpful. I think knowing the mode of inheritance is really critical. There may be a handful of genes that I think are good to know, and we try to outline those in a lot of the lectures. For example, if you look at AAN content outline, AAN recommends certain genetic tests for hereditary neuropathies. Well, I would probably know what PMP22 is. But board exam is much more likely to emphasize how do you counsel the patient and their family, right? So a patient with hereditary ALS, and the gene is C9orf72. What's the mode of inheritance, right? Because that's really now how do we counsel families? What do we do with this information? More than esoterically, well, what's the specific chromosome the gene's on? That's the sort of stuff USMLE does and why they're getting rid of some of it. So thinking more on, well, what would my role as a neurologist be? Well, it's to, a lot of it has to do with, hey, the patient question, how do I counsel my family about this diagnosis? So I think focusing more on mode of inheritance for the counseling aspect is much more critical. Again, though, I think it's important to focus on what a neurologist does. We're not pathologists, we're not radiologists. We are considered by our board psychiatry, neurology, and pediatric neurology. So some of that's going to show up on your exam. So psychiatric disorders, neuropsychology, and pediatric neurology, those are all worth the same number of points. It's a smaller percentage of the test. In the past, you had to pass each section of the test individually. That is no longer the case. You have to pass the exam in its totality. Traditionally, I will tell you, the place that neurologists get tripped up the most is going to be in their peds and their psychiatry, for a simple reason. This isn't what you do on a day-to-day, week-to-week basis, right? You generally speaking, you spend most of your time treating adult patients with neurologic disorders. But there will be questions on psychiatry and on pediatric neurology. So those are going to be probably the more challenging questions because they aren't a part of your routine practice. So you can't rely as much on some of your clinical experiences to answer questions as much as what you're gonna kind of focus on. So this is where the content outline, I think, is extremely helpful. I'm not a pediatric neurologist, so what do I need to know? I do in my own personal practice, I do a lot of neuromuscular care, and I do a lot of multiple sclerosis and demyelinating diseases. I admittedly am not as comfortable with pediatric dysmyelinating disorders. So when I prepared for my recertification examination, when I do the lecture for my residents on demyelinating conditions, what I find to be really helpful is looking at the peds and psych aspects of the outline. For pediatric neurology, genetic and developmental disorders really bullet points out the diagnoses you have to know. And I find that to be extremely high yield. You know you're going to get a question on one of those, and it tells you which one specifically. It doesn't tell you the exact one, but it's going to give you a list of maybe 6 to 8 dysmyelinating disorders. You also will want to take a look at the epilepsy section where a number of the epilepsy diagnoses come up. Think about how do I make the diagnosis and how do I counsel the patient and their family about long-term risks. So psychiatry also has a pretty lengthy and very dedicated section in the blueprint. It is, I find, to be highly specific. I would spend some time on that, right? This is my own personal feeling and one I tell our residents. Decide how you want to prepare for psych and peds. Think about what you're going to be doing in the fall and what you're going to be doing in the spring. You're going to be doing some aspects of neurology. If you're going to be a stroke fellow, you're going to be a critical care fellow, you're going to be an epilepsy fellow, you're going to spend a lot of time doing that. You probably don't need to study stroke. We actually tell our residents not to, we have a pretty stroke heavy program. We tell our residents not to study stroke, right? We're doing it day in, day out. Maybe a quick review, but man, we do a lot of that stuff. Think about what you don't do. And so think about peds and psych, how are you going to prepare for that? You've got time here, hopefully, over the next couple months, really kind of think about putting together how you want to study. And I think some of the review lectures are really great. Man, that's the thing I would probably study at the end, right? So maybe spend a little time now preparing how you're going to study it. But that to me is maybe the last thing that I'm going to study. And the simple idea for me being, I'm probably not going to remember this. I will tell you, I'm going to keep kind of going back to pediatric dysmyelinating disorders. I know it once a year for about 2 days when I give the lecture. And then I rarely see pediatric dysmyelinating disorders, right? And if I see it, I think I can generally kind of recognize it, but am I going to know all the nuances of a specific disorder? No. So if I'm taking my exam, that's the thing I'm probably going to study right before the exam, right? The couple of days or week or two before, and really kind of do that rote memorization, kind of going back to what you did in your pre-med and medical school courses, and getting ready for that material that's just not part of your routine practice on a day-to-day basis. So that's my own preferred study strategy. I really like the things that weren't part of my routine practice, things I don't do regularly. I like to kind of keep near the end with the idea that, if I spend the next 2 weeks studying peds and I got to take a test in 6 months, I probably won't remember it. So I prefer to kind of have a plan for how I'm going to do it, maybe prep my materials now, but really study that more towards the end. Last piece of advice, as you guys are getting ready, and I think this is the time to really start kind of buckling down and getting ready to a certain extent, and getting your notes together. Hopefully, if you're a senior resident, you've got some time here. If you're already in practice, it's probably even more important to be really efficient with your time. This is just a written test. This doesn't determine your worth, your value as a neurologist. You've already proven that. You've put a lot of work in over the last several years in your residency, your fellowships, maybe in your personal practice. Your ability to work as a neurologist has, to a large extent, already been determined. You've earned that competency through taking call, doing work, et cetera. This is just a test to confirm objective medical knowledge. And that's it. It doesn't say if you're a great neurologist, average neurologist, whatever. You already proved that, right, with the work that you do. So your goal is to get prepared, go out there, take the test, and then move on, right, and be done with it. So with that, I will stop. I spent about half the time just trying to go kind of broad bucket here, kind of giving you sort of set the table a little bit with maybe what to expect for that examination. Obviously, the lectures are going to get into a lot more nitty gritty.